Good afternoon, our dear students. Now we have a lecture in Propaedeutics of internal medicine. According to high widespread of COVID-19 in Kharkov especially and in Ukraine, we shift our lecture cycles for online, but we still continue our education, and for practical class we are waiting for you at our department. And about lecture cycle, now I don't know for what term we have all online lectures, and all my lectures you can see here on my YouTube channel, and lectures of our teachers in our department for third and fourth year students in internal medicine you can find here. We save all recordings. You can return to this lecture, you can repeat some material. According to your schedule, according to schedule time, we have a live format of our lecture this year. That's why in your usual time you can switch YouTube channel, and online you can see this lecture. As several rules, I remind you, because we have several months without online. Yes, during streaming, I ask all students who are listening to write your name and number of group in comments under this video. After the lecture, if you have comments, if you have some questions or for example, some recommendations, you can write it here on YouTube channel under the video in comments, or you can write it in our closed Facebook group that is connected just with our department. You can write your questions, for example, or some comments there, and we are always in contact. We always will be glad to answer you and to give some reaction. If you remember previous lecture with third year students, we started cycle in cardiological lectures in Propaedeutics of internal medicine. The name of this submodule was Signs and Symptoms of Cardiovascular System Diseases. Our previous lecture was about general examination of cardiovascular system. And now we're studying some specific syndromes. And topic of our today's lecture, it is syndrome of arterial hypertension. Okay, plan of our today's lecture. We will give definition, we will discuss classification, causes of arterial hypertension, clinical picture and diagnostics of arterial hypertension, and small picture for you, like a reminding what is blood pressure in general. When blood flowing inside the vessels exert a force against the walls, we name it blood pressure. Yes, it is a power which push to the vessels during blood flow. Okay, let's give definition. What is arterial hypertension, or just hypertension? Also known as high blood pressure or arterial hypertension. It is a chronic medical condition in which the blood pressure in arteries is elevated. Hypertension is having a blood pressure higher than 139 or 89. Or more than 140 and or more than 90 millimeters hydrorgium for most adults. Different criteria applied to the children. And here I want to stop on this moment, because it is the most usual norm. It was actual in all world several years ago, and in Europe and European countries it is still actual that for normal healthy not healthy but usual adults, for most adults without significant risk factors, the criteria for hypertension 140 by 90. But several years ago the American Heart Association they change a little bit their criteria, change a little bit the guidelines, and there in American guidelines, for now, criteria is 130 by 95. It is a little bit lower. That's why criteria is lower and bigger number of people become hypertensive according to this new criteria, because researchers showed that these people from 135 till 140, they are in the same high risk for different complications as other hypertensive people. That's why American guidelines decrease a little bit their hypertensive levels. But for Europe and Ukraine, because we use European criteria, for us the level of hypertension 140 by 90. Okay, types of arterial hypertension. In general, it can be primary and secondary. Primary, or another name of this hypertension, is essential. It is 90%, even more than 90% of all cases. Most of people, hypertensive people that you will see during your practice, will have essential hypertension. It's defined as high blood pressure with no obvious underlying cause. It means that more than 90% of all hypertensive people that you will meet in your practice, you can't find any cause of hypertension, any significant exact cause. Of course, all of them will have a lot of different risk factors, and now we will discuss these risk factors. But it's not one exact cause that lead to hypertension. That's why no cause. We name it essential or primary hypertension. Sorry, I have some tea because I have sore throat. And other people, less than 10% of cases, have secondary hypertension. It's defined as a high blood pressure due to identifiable cause, or we can find one significant and exact cause of this hypertension. What the most often situation? It is chronic kidney disease, narrowing of the aorta and kidney arteries, different endocrine disorders, and mostly it is excess aldosterone, excess cortisol, excess catecholamines, overproduction, both hyper and hypothyroidism, and other endocrine and metabolic disorders. And let's classify it. We have clinical classification of arterial hypertension. We classify it due to level of blood pressure. One more time, I want to stop that you can in different guidelines meet different criteria, but European criteria and Ukrainian criteria are the same. Normal blood pressure, it's from 90 to 119 systolic and from 60 to 79 diastolic. High normal blood pressure, it from 120 to 139 systolic and from 90 to 80 from 80 to 89 it is diastolic. And all that more than 140 and 90 it is hypertension. And hypertension we can divide into 3 degrees or 3 stages. Stage 1 hypertension, it when the blood pressure systolic from 140 to 159 and diastolic from 90 to 99. Stage 2, it when systolic blood pressure from 160 to 179 and diastolic from 100 to 109. And stage 3 hypertension, it is a hypertensive emergency or hypertensive crisis. It when systolic blood pressure more than 180 and diastolic blood pressure more than 110. And we have one more specific type of hypertension. We name it isolated hypertension. It's very typical for aged people. For patients with polymorbidity, It when the systolic blood pressure elevated more than 140, but diastolic it usually normal, less than 90, and it can be even decreased like 15, 55, 60, usually not higher, and systolic blood pressure will be high. Okay, causes of primary hypertension. I told you that primary or essential hypertension don't have any significant cause, but we have a complex of different etiological risk factors, and complex of them and interactions between them lead to hypertension in each individual patient. Hypertension results from a complex, what I told, of interaction of genes and environmental factors. Numerous common genetic variants with small effects on blood pressure have been identified, as well as some rare genetic variants with large effects on blood pressure, but the genetic basis of hypertension is still poorly understood. Causes of secondary hypertension. Here we name in definition several of them. Let's stop one more time on it. Most often such disorders lead to secondary hypertension. It is kidney disease, it is Cushing syndrome or overproduction of cortisol. It is hyper and hypothyroidism, both situation as with excess hormone secretion as with deficiency of hormone secretion. Thyroid problem can lead to hypertension and very often lead to hypertension. Acromegaly, it is overproduction of somatostatin or growth hormone. It is Conn's syndrome. It is hyperaldosteronism with other causes. It is hyperparathyroidism. It is pheochromocytoma, obesity, sleep apnea, pregnancy. It can be drug-induced hypertension, etc. Other more rare causes. Okay, and risk factor or hypertensinogenic factors. What factors can lead to hypertension in general, as primary as secondary, and especially it is important for us for primary because, one more time, we don't have any significant causes, but at least knowing of risk factors that lead to hypertension, that connected with hypertension, very important for us as a doctors, because most of these factors are modifiable, and by modifying these risk factors we can treat hypertension more effectively. What factors? It is age, race, sex, family history. It was not modifiable, yes, and modifiable factors. It is obesity, it is sedentary lifestyle, it is insulin resistance, it is using tobacco, it is high alcohol intake, it is high salt intake, stress, dyslipidemia, low potassium intake, low calcium intake, too little vitamin D in diet, and certain chronic disorders. Okay, score for evaluating of arterial hypertension. You can find it in those site heartscore.com. Score or systematic coronary risk evaluation. It is a cardiovascular disease risk assessment system initiated by European Society of Cardiology. Score is based on risk factors like gender, age, smoking, systolic blood pressure, and total cholesterol. Height score is interactive version of score. The threshold of high risk based on fatal cardiovascular events is defined as higher than 5% instead of the previous higher than 20% using a composite coronary endpoint. Yes, and this score, this scale of score, looks like this. It is a table, and you see, according to risk factors, yes, one more time, we include here blood pressure, chronic kidney disease, organ damage, dyslipidemia, and presence of diabetes mellitus and level of blood pressure we can include. We can put in diagnosis level of cardiovascular risk, and for today it is obligatory classification for putting diagnosis hypertension. You put hypertension, stage and level of cardiovascular risk in score. It is score 1, 2, 3, 4, or low risk, moderate risk, high risk, and very high risk. And you see that it is no risk or low risk. It is when high normal or high normal arterial pressure, and no risk factors or 1-2 risk factors. If it is 3 and more risk factors, or if it is systolic grade 2 hypertension with systolic from more than 160 and diastolic more than 100, it will be moderate risk. If it is 3 and more than 3 risk factors, or organs damage, or presence of diabetes mellitus, it is automatically goes to the high risk. Do you see? According to the table, even with normal blood pressure, diabetic patient or patient with organ damage have a moderate to high risk of cardiovascular disease. And if it even grade 1 hypertension and higher, it is a high cardiovascular risk. And if it's symptomatic coronary vascular disease, if it's chronic kidney disease or stage more than 4, or diabetes, all these patients has very high risk, or score 4 for hypertension. Okay, in pathophysiology of arterial hypertension, we can find such key factors. It is a very schematical, and more you can read at home during preparation to your practical class, but like a conspect main of them. First, it is abnormal sodium transport. Next, it is increased sympathetic nervous activity. Next, it is increased renin-angiotensin-aldosterone system activity. And fourth one, it is vasodilator deficiency. If you don't remember mechanism of each of these hypertensive factors, please repeat it at home, because it is very important to understanding as diagnostic of arterial hypertension as treatment of it. Okay, and let's discuss signs and symptoms of hypertension. Most people with high blood pressure have no signs or symptoms. It is a very important moment. Even if blood pressure readings reach dangerously high levels, most people, even with high pressure, do not feel anything. They don't have any clinical symptomatic, and for such patients, usually finding a hypertension, it is spontaneous finding. For example, during usual follow-up of this person. A few people with a high blood pressure may have headaches, shortness of breath, or nosebleeds, but these signs and symptoms are not specific and usually don't occur until high blood pressure has reached a severe or life-threatening stage. Main complications. Hypertension is a danger for people not due to direct influence of blood pressure, but it very danger according to its damaging of vessels. As small vessels as large vessels usually are in high risk in all hypertensive people, and it leads to a very severe complications that lead to high morbidity and even high mortality. And what the most often complication? All of them are vascular. It is hypertensive heart disease. Yes, it is transformation of myocardium and changing of size and shape of the heart due to increased pressure with hypertrophy of left ventricle, and it can be diffuse hypertrophy of all heart. Next, it is provoking and worsening of coronary artery disease through the worsening of atherosclerosis, because it is additional damaging factor of vessels. And if you remember pathophysiology of atherosclerosis, blood pressure, one of the most important factors, one of the most important link in pathophysiology of atherosclerosis. Other manifestations of atherosclerosis, it can be stroke, it can be peripheral artery disease, it can be hypertensive retinopathy. Moreover, hypertension can lead to aortic aneurysm, to chronic kidney disease and chronic heart failure, like a result of hypertensive heart disease. The known duration of hypertension and previously recorded levels is important in medical history of the patient. First of all, when you see patient with hypertension, when you take anamnesis in this patient, you ask history of disease. If here disease is hypertension, you ask when was the first manifestation and what levels of this hypertension was through this period. It can be day, it can be month, it can be 10 years. In different patient, different anamnesis. And you detailized everything. What the middle level of arterial blood pressure. What the highest level of blood pressure that you ever checked? What are the level of blood pressure when you feel okay? What is normal for you? It can be very individual. For example, patient with undiagnosed hypertension, for example, during several years, it can be asymptomatic, I told you, and this patient does not feel any symptom, for example, at pressure 150 by 100. Yes, it's normal. It is first degree not normal, it's first degree hypertension, but for patient it's okay. And we diagnosed hypertension, and these people prescribe tablets, prescribe antihypertensive drugs, and patient feel that it decreasing our blood pressure, but patient suffer from some dizziness. It can be headaches, it can be some weakness during first time. That's why decreasement of pressure for this patient have to be very, very gradual. And for you, it is important diagnostic moment that for each people with hypertension, the normal level, it is level when patient feel any symptoms and feels okay. It can be absolutely different, not always normal. It can be too high, it can be too low pressure for each patient, individual level. But if it's high, we have it gradually decreased with our management. Any history or symptoms of coronary artery disease and heart failure are very important in medical history too. You see that in all our lecture it connected with hypertension, and it can be direct connection from hypertension to coronary artery disease and heart failure like a result, and opposite influence if it previous was coronary artery disease and heart failure like a result. In some cases it can lead to hypertension. That's why this connection is both-sided. Moreover, in medical history, we ask patients about other relevant coexisting disorders like stroke, renal dysfunction, peripheral arterial disease, dyslipidemia, diabetes, gout, etc. Of course, we always ask about family history of any of these disorders. We are interested in social history, includes exercise level and use of tobacco, alcohol, and stimulant drugs. Is it prescribed or illicit? Because we discuss in risk factor, it can be provoking factors and we need to remove it for better management of the patient. A dietary history focuses on intake of salt and stimulants like tea, coffee, caffeine-containing sodas, and energy drinks. We detailize lifestyle factors in this patient. For example, it is excess stresses during work. Yes, it is additional provoking factor for hypertension, and we should know about it. And during treatment of this patient, we have to manage this stress. Of course, we detailed current and previous medications as for hypertension as for other disorders, because you know that it can be drug induced, and for example patient use some other drugs, rheumatological, oncological, gastroenterological, other cardiological drugs for other problems, but some of them can lead to hypertensive symptoms. Okay, and what is interesting during physical examination? First of all, for this patient, you check height, weight, and waist circumference, because here, if you remember slide with risk factors, one of the first places take obesity. And here the most important, especially abdominal obesity, it is the person who is obese due to abdomen. When high and low extremities are not very thick, yes, they are usually normal, or a little bit widened, but patient is significantly obese by the abdomen. And for checking this parameter, we use general checking of BMI. If you remember from previous lecture, it is body mass index. It is a relation between weight and height. And according to this BMI, we can check, is it normal weight, is it overweight patient, or it is some degree of obesity. And what I told you about, that here it is a very important, especially abdominal obesity. Here even the more specific sign, it is waist circumference. We take patient and just check circumference of the waist of the patient, and according to it we can say is it present or not abdominal obesity. Moreover, of usual objective examination, of course you do everything. You do general inspection, you do percussion, palpation, auscultation. Now in this lecture I stop just on specific signs for hypertension. Additionally to usual methods, we do fundoscopic examination for retinopathy, because hypertension, it is one of the leading cause of retinopathies in general, and such a serious complication like blindness. Because don't lose hypertensive retinopathy in hypertensive patient, we always should check fundoscopic examination. During auscultation for bruits in the neck and abdomen, unilateral renal artery bruit may be heard in slim patients with renal vascular hypertension. Yes, it is a very important method for all hypertensive patients. We usually do it when we put stethoscope on abdomen in points of projection of renal arteries. Why we should do it? Because we have to exclude secondary hypertension. Sorry. Okay, let's stop for it for a minute. We have essential hypertension, that is primary. We have secondary hypertension. Yes, most patients are essential and we don't find any cause, but it have to be exclusive diagnosis. What mean exclusive diagnosis? You have to exclude during examination all other causes. Of course, because knowing of the most patients are essential. Don't let you do CT, lab analysis, ultrasound of everything, MRI of everything. You don't do it to exclude everything that able, but during examination you have to be the most attentive, because you don't need additional cost, you don't need a lot of additional time. And it's very simple as for you, like a doctor, as for patient, to exclude the most important cause. And renal, for example, renal artery stenosis, it is one of the often cause of secondary hypertension. That's why such a easy manipulation like auscultation of renal arteries help you to exclude. If you suspect something, do you have any even not significant bruit, you can send this patient to ultrasound of renal arteries. But for example, if it is aged patient with no significant metabolic endocrine disorders, no significant renal problems, it is enough to exclude renal artery stenosis if you don't hear anything. That's why during objective examination in hypertensive patient, you have to be very, very careful. Don't lose something, because after it, additional instrumental and laboratory methods you will prescribe just based on your objective examination, just due to suspicious, not to check in everything. Okay, and of course it is full cardiac, respiratory and neurological examination. Why? You should understand. We discussed that it is a lot of different cardiovascular, neurological, respiratory problems resulting in hypertension. That's why you should find all of them. Okay, what can we hear during heart auscultation? A fourth heart sound is one of the earliest signs of hypertensive heart disease. During transformation of myocardium and changing of heart structure, it can start in fourth heart sound. If you remember heart auscultation, normally it is two heart sound. You don't hear not as 3, not as 4. If it is hypertensive heart, even it is asymptomatic and patient can don't even know that has hypertension, during auscultation you can hear a fourth heart sound or S4, and it sent you for a mind that it can be hypertensive heart, and it confirm for you that this patient during some period, significant period, had previous hypertension. Okay, in abdomen palpation you can find kidney enlargement. It's really difficult to find it, but possible if patient is not very obese, and for different abdominal masses. Peripheral arterial pulses investigation. It is diminished or delayed femoral pulses suggest aortic coarctation, particularly in patients less than 30. It type of secondary hypertension that we didn't stop on, but maybe you learn it in heart defects, valve defects, congenital heart defects, and such defect we are interested in, like aorta coarctation. And it really causes a significant hypertension. But that specific sign that you find this hypertension just in upper part of the body, and all lower extremities it will be normal or decreased pressure, and it will be diminished or delayed femoral pulses and low extremital pulses in general. It is sign of aorta coarctation and secondary hypertension due to this coarctation. Okay, and I told that that third degree of hypertension, usually connected with hypertensive crisis. It is cardiovascular emergency with severely elevated blood pressure equal or greater than systolic 180 or diastolic 110 is referred to an hypertensive crisis. I want to stop on definition because not all patients with pressure 180 by 110 are in crisis in this moment. Really, a lot of untreated patients that feel not okay, but not too bad. It is not a very symptomatic. It can be some headache. It can be some hot feeling, but maybe some pulsation in the head, but not significant. It is not significant symptomatic, and we usually don't diagnose in this patient crisis, even if pressure more than 180 by 110. But usually it is a very severe pressure that goes with a very bright clinical symptomatic, and we name it hypertensive crisis. It categorized like hypertensive urgency according to presence or absence of end organ damage. Most affected organs include brain, kidney, heart, aorta, and lungs. You understand, it is very dangerous for bleeding or thrombosis. Diagnostics. First of all, of course, it is multiple measurements of blood pressure to confirm. Yes, one checking and finding elevated blood pressure during one checking is not enough for diagnosing of blood pressure. It have to be some series of measurements and confirming by constant elevated blood pressure. Additionally to checking blood pressure, but not for confirming diagnosis, for confirming or excluding different causes and different complications. We use urinalysis and urinary albumin. We are interested in creatinine ratio because we have to exclude chronic kidney disease with kidney failure. In blood test, usual panel for patients with hypertension, it is fasting lipids, hematocrit, creatinine, serum potassium, creatinine or the corresponding estimated glomerular filtration rate that is usually calculated from creatinine, calcium, lipid profile, and glucose. Moreover, we usually do for patients with suspected renal problems, and it is a lot of patients when with suspected renal problems, it is renal ultrasonography. Evaluate for aldosteronism if calcium decreased. On ECG, if left ventricle hypertrophy, it considered echocardiographically. We can suspect hypertensive heart and hypertrophy of left ventricle, but we can confirm it just with echocardiography. Okay, sorry, previous one. Sometimes, but it really often, measurements of thyroid stimulating hormone, T3, T4 hormones, it's really often because we are absolutely endemic for thyroid problems, and really a lot of people have thyroid problems. We have to exclude, you remember, as hyper, as hypothyroidism. Both of them can lead to hypertension and can worsening previous hypertension, worsening its course. Usually in some patients we check cortisol level because Cushing syndrome and disease can worsen in hypertension too. Evaluation for pheochromocytoma or sleep disorders. You remember sleep apnea can be cause of hypertension. We do if blood pressure elevation sudden and labile or severe. Okay, Patient should be seated for blood pressure monitoring comfortably with the back supported and upper arm bared without constrictive clothing. The legs should not be crossed. The arm should be supported at the level of the heart and the bladder of the blood pressure. Cut should encircle at least 80% of the arm circumference. The blood pressure measurement device should be deflated at the rate of 2 to 3 millimeters per second, and first and last audible sounds should be taken as systolic and diastolic pressure respectively. Neither for the patient nor the observer should talk during the measurement. One more time, office blood pressure. It is a pressure that check in the office in a room of the doctor or in another room in the hospital when the patient go to the doctor or to the nurse, for example, for any medical specialist. All rules I describe in these two slides based on practical classes at home, in your room with your friends. Please practice it and try it to each other to checking blood pressure with keeping all these rules. Yes, it's not such as simple as look for the first view, but all these rules are really important because changing of this condition can lead to some false result of blood pressure measurements. Measurements may be both while seated and after standing to look to the orthostatic or postural hypertension. At least the first measurement should be done on right and left arms. One more time, if your patient see first time, it is a new patient. It is a new patient for you. You always should check pressure in right and left arms because it can be peripheral artery disease with significant atherosclerosis, and for example in one arm in this case the pressure can be significantly lower than in another, and for example you check in an arm with a lower pressure and don't diagnose hypertension properly. In most cases, we check in sitting and standing position to exclude orthostatic hypotension. It looks usually like this, yes. On this picture, you see man getting his blood pressure taken in the doctor's office. Yes, sitting position. You see proper position of the arm. You can check heart sounds with stethoscope or, like in this picture, palpatory, like this medical specialist, and checking for blood pressure in doctor's office. And why we talk about office blood pressure? Because we have ambulatory blood pressure monitoring, and it is a very important moment in diagnosing hypertension. The National Institute of Health and Clinical Excellence guidelines recommended that a diagnosis of primary hypertension should be confirmed with a 24-hour ambulatory blood pressure monitoring or home blood pressure monitoring rather than by relying solely on the office blood pressure measurements. 24-hour ambulatory blood pressure monitoring is indicated to rule out the white coat hypertension, to uncover apparent drug resistance or office resistance, to better define resistant hypertension, to identify hypotensive system while the patient is being treated with antihypertensive medications and autonomic dysfunction states. Now I'll show it what is white coat hypertension. 24-hour ambulatory BP monitoring also helped identify abnormal patterns in blood pressure that could remain undetected if patient is elevated based on physician office blood pressure measurements alone. We can check as too low as too high episodes of blood pressure during daily activity of the patient, because the office of the doctor, it is artificial condition for this patient, and in most cases this patient can be in stress, and we got white coat hypertension, and during day it's all okay. Or rare, we can have the opposite situation when the patient during visit is relaxed, patient in rest, and we check blood pressure is okay, and for example at work or at home it has a lot of stress and patient got a lot of episodes of hypertensive periods. Yes, and it looks like this. During 24 hours we got after monitoring such a scheme when we see a peaks of blood pressure, the lowest level of blood pressure, some middle during day, during night, some middle level of hypertension. Okay. The extent of the nighttime blood pressure attenuation has been mainly quantified through the so-called sleep time relative BP decline. It have to be some decline during night, which is defined as the percent decrease in mean blood pressure during nighttime sleep relative in the mean blood pressure during daytime activities. The information how significant during night blood pressure decreases is a very important diagnostical sign for us too, and according to this decreasement it have to be, is it normal or is it over decreasement, or it's not enough decreasement, or it even elevated blood pressure during night. It is important diagnostical information. And according to this type of night blood pressure, we can classify this blood pressure attenuation. We classified all individuals into 4 groups. We named extreme dippers when sleep time relative BP decline more than 20%. It is a too significant decrease of night blood pressure. Next group, we name it dippers when sleep time relative BP decline on more than 10%, but less than 20%, it is normal. Next group, it is non-dipper when sleep time relative BP declines less than 10%. And inverse dippers or risers, it is sleep time relative blood pressure declines are less than 0. It is when it increased, indicating at sleep blood pressure higher than awake blood pressure. Okay, and on this scheme you see 24-hour systolic blood pressure pattern dashed by thick line, you see, of a normotensive deeper subject at the left and hypertensive extreme deeper patient at the right, plotter with respect to circadian time specified tolerance limit with a continuous thin lines. You see by the thick lines on left picture it is deeper, it is normal, it is yet present some decreasement but not a very significant, and second picture it is much more high, much more severe decreasement, it is extreme deeper. Here as a systolic blood pressure pattern dashed by thick line of hypertensive non-dipper at the left and hypertensive riser patient at the right. Plotted with respect to circadian time specified tolerance limit, it is continuous thin lines calculated from reference population normotensive individual as a function of their rest activities, cycle and sex. You see by the thin lines it is a middle-like population numbers, and you see that first picture it is non-deeper when it is decreased during night but not enough decrease, and the last picture at the right you see that it nearly no decreasement during a night at all. Okay, and home blood pressure monitoring. The home blood pressure is better predictor of cardiovascular morbidity and mortality than are office blood pressure measurements. Hypertension is defined as a mean home blood pressure of more than 135 by 85. You see a little bit another limit for home blood pressure. It's not 24 constant monitoring, it is checking of patient by him or herself or by their relatives, for example, but at home, not by the doctor. Home blood pressure monitoring provides an inexpensive alternative for 24-hour ambulatory BP monitoring, which is not yet widely available. One of the main drawbacks in a home blood pressure measurements when compared to 24-hour ambulatory BP monitoring is that sleep time blood pressure can't be recorded, and therefore those patients with abnormal dipping pattern in blood pressure and nocturnal hypertension can be missed. It is a very good method, and really in a lot of patients we don't use 24 hours monitoring. It's not such widely available, and it's not very comfortable for patient during 24 hours go with this device and with manchettes for, which every 5-10 minutes press very significantly their arms. Yes, it is abnormal sleeping and abnormal day, not very comfortable. In most patients we use just home blood pressure monitoring individual by this patient. We ask patient to check individually, educate how to check, and patient individually check and fix it in paper what level of blood pressure. But we have one limitation that patient can check it during night because patient is sleeping. And one more important index, it is ankle brachial index. The ankle brachial pressure index, or ABPI, or ankle brachial index ABI, is the ratio of the blood pressure in the lower legs to the blood pressure in the arms. Compared to the arm, lower blood pressure in the leg is an indication of blocked arteries, peripheral artery disease, or PAD, or secondary arterial hypertension due to aortic coarctation. And you see a table of interpretation of ankle brachial index. Yes, you see if it above than 1.2, it is abnormal vessel hardening from PVD. From 1 to 1.2, it is normal range. From 0.9 to 1, it is acceptable. From 0.8 to 0.9, it is some arterial disease. From 0.5 to 0.8, it is moderate arterial disease, and under the 0.5, it is severe peripheral arterial disease with the needing of urgent specialist referral. And one more time, what is white coat hypertension? It is a patient that feel some stress. It is unexplained. Patient even can't pay attention to it, and patient usually don't feel stress. But when we check blood pressure in the doctor's office, it is elevated and it is referred to hypertension, and in ambulatory monitoring, patient do not fix any hypertension, and his or her blood pressure is not elevated at all. And in systemic case, and we have really a lot of such patient who has hypertension just in office or doctor, we name it white coat hypertension. Yes, and for fun, you have the picture here. Maybe it is time to change color and model of coat, like some possible decision. But I think that problem not in white coat, problem in some stress and maybe not some for patient not reliable visit to the doctors. And how to check? We have clinical pressure and we have mean 24-hour ambulatory pressure according to monitoring 24 hours or personal monitoring. Yes, if both of them normal, it is true normotension. Is clinical elevated but ambulatory normal, it is white coat hypertension. If clinical, possible more rare but possible, I told you, clinical pressure is normal, but during ambulatory monitoring, and patient systemically fix elevated blood pressure, it will be masked hypertension. You should understand that this patient is hypertensive already. And if both of them are elevated, understandable, it is sustained hypertension. Okay, white-hot hypertension. Let's stop one more time. More commonly known as white coat syndrome, it is a phenomenon in which patients exhibit a blood pressure level above the normal range in a clinical setting, though they don't exhibit in other settings. It is believed that phenomenon is due to anxiety that those afflicted experience during a clinic visit. Okay, masked hypertension. The term masked hypertension describes the contrast in the white coat hypertension phenomenon. The opposite, yes, when the office pressure is normal but home ambulatory pressure systematically elevated. Okay, let's talk a little bit about complications, and one of the danger and very important complication I want to stop on retinopathy. I want to stop in lecture because all other complications like coronary artery disease, like encephalopathy, you usually pay more attention during your individual education and practical class. But for students, very often you lose a lot of information about the retinopathy. That's why I stop on retinopathy here and lecture, because you have to be in your future practice, be very attentively with it. Okay, hypertensive retinopathy, it is a damage of retina and retinal circulation due to high blood pressure. Grades of hypertensive retinopathy, or it is classification according to Kate Wegener-Barker. First, it is arteriolar constriction, attenuation, sclerosis, silver wiring, and vascular thrombocytis. Picture we'll discuss a little bit later. Second one. It is a grade 1 plus irregularly located tight constrictions known as AV nicking or AV nipping. Grade 4 as a grade 2 plus retinal edema, cotton wool spot, and flame hemorrhages. Previous here it was grade 3. It is a mistake in a presentation, and here grade 4, it is like a grade 3 swelling of the optic disc, papillar edema, and macular star. And you see here picture, it is the same on all slides with different situations with macula. And here you can see in different picture signs of peripapillary and periarterial retinal changes are apparent, including cotton wool spots, retinal hemorrhages, and exudate. And for your interest, you can stop presentation at this moment, zoom a little bit this picture, and according to classification find for what picture what stage of retinopathy is present. Yes, to check hypertensive retinopathy, we use ophthalmoscopy. It is manipulation, not just ophthalmologist. You have to do it and you have to know it like a general practitioner during general examination, if ophthalmoscope is available just now for you. And here you see picture, it is a photo of normal fundus and structure of this fundus from anatomy. I hope you remember optic disc, macular, vessels and other structures. Okay, kidney problems. Kidney problems we usually confirm laboratory tests we discussed already. And instrumental visualization, and the most usable device here, it is sonography. And on renal sonography, here you see an example. It is a patient in which the size of left kidney is small. It is 8.37 centimeters is length. It is decreased size of kidney, and echogenicity of the kidney is increased in a patient with left renal artery stenosis. And diagnostics confirming of renal artery stenosis. Yes, I remind you that first sign for suspecting it is auscultation of renal arteries. You have to hear some roots. Next step, during laboratory examination, we always check creatinine. If we check creatinine, it is a sign for more detailed checking of kidney. And after this checking, we can use such methodic. And on this picture, you see first picture, it is a renal artery ultrasound with Doppler methodic that help you to evaluate blood flow. And second picture, it is arteriography with visualizing of structure of arteries. First picture, Doppler screening for renal artery stenosis show very high velocity flow at the level of left renal artery origin from aorta. That is sign of renal artery stenosis. And second picture, it is subsequent arteriogram, shows tight stenosis at the left renal artery ostium. You see by the red arrow how interesting and significant, very visible stenosis of renal artery here. It can lead to chronic kidney disease, and it can lead through the kidney mechanism to secondary arterial hypertension. And one more picture of renal color duplex sonography. It is ultrasound methodic or sonographic methodic too. Here you see the normal appearance of right renal artery, right accessory renal artery. Here you see by two arrows, two arteries. It have to be just one. Single left renal artery, another arrows on the another side, and abdominal aorta on longitudinal view of color floor image. By left renal artery, you see here it is two go to the right and just one to the left. It is a variant of abnormal congenital abnormal growing of arteries. Another situation, it is color duplex sonography too, and here you see remarkably turbulent flow at the stenosis of the right proximal renal artery on longitudinal view of color flow image. Yes, Doppler sonography, it goes with the color, and in artery it have to be one direction, like in red or yellow-red color, but you see that it some according to by arrows it showed some turbulence blue floors. That means that it's something abnormal with floor here, and it caused by stenosis. One more renal color duplex sonography demonstrating high peak systolic velocity and high renal artery with hemodynamically significant stenosis. It is the same with previous picture but more severe. uh, MRI renal imaging, and you see the stenosis of right proximal renal artery. In the starting, in the first part of this artery near the aorta, it is significant stenosis of right renal artery. And one more method, it is a renal radionuclide image. We rarely use it for hypertensive patient, isolated hypertension, but it's possible. Here you see imaging of kidneys involves intravenous injection of technetium magnesium 3 or mercaptoacetyl triglycerin and lying on table for hour more than while imaged by gamma camera. And these ions, they are accumulated in kidneys, and we, according to series of pictures, we can visualize structure of kidneys. Okay, in some cases we should do brain magnetic resonance imaging. When we suspect some problems with brain, it is a stroke, it can be ischemic stroke, and it can be bleedings, macrobleedings, microbleedings. In this case, the most informative visualization is MRI. Okay, brain macrobleeds in arterial hypertension patient are seen as small, homogeneous, around 40 and low signal intensity. In different pictures you can see by arrows. If you zoom a little bit by small arrows, you will see it like a small points. It's microbleedings after some high blood pressure episode, especially hypertensive crisis, which is very special for hypertensive patients. Okay, in most patients we usually use chest X-ray. It's a very simple, cheap and good method of visualization of heart form and shape. And here you see a chest X-ray that's suggesting a definite left ventricle enlargement. You see the form of heart, it is enlarged, it is a shape moved to the left with a hypertrophy of left ventricle. Okay, and indications. Today we stop a lot on kidney problems like complication, like a result of hypertension. In what cases we have to do ultrasonography? One more time, if urinalysis detects albuminuria or proteinuria, cylindruria or microhematuria, or if serum creatinine is elevated more than 1.4 milligrams per deciliter in men and 1.2 milligrams per deciliter in women, and renal ultrasonography to evaluate kidney size may provide useful information. Okay, for today that's all. That is the main information that I want to talk to you. Of course, it's not all about hypertension. It's not all about diagnostics of hypertension. Much more information you have for your individual work. And if you have some difficult moments, if you have some questions, one more time I remind you that you can write your questions in comments, or better in our Facebook page, and we are always ready to some feedback for you, and you will discuss on practical classes with your teachers. One more time I ask everyone to write your name and group in comments on YouTube under the video. And I hope everyone will be healthy. I hope no one will get not COVID, no another disease. And in a quick time, we will meet in classroom and we will have offline lectures. But for today, that's all. And see you in 2 weeks on the next lecture here on YouTube. For today, that's all. Goodbye.